Dear pure urology viewers, good evening one and all. Today our topic is ECIRS, endoscopic combined intrarenal surgery. As you all know, from 1990, Professor Michael Grasso has made a lot of efforts to make the RIRS popular. After that, Dr. Oliver Traxler in the modern urology has changed the entire thing by his teachings and live surgeries. So by 2000, RIRS is very much into the practice. But 2012-13, Caesar Scaffold and some other people have made supine piscinal and RIRS together as ECRS. Supine piscinal was there way before, but somehow not practiced. Not many people have accepted it, have practiced it. But somehow after 2012 and 15, it again popularized after the RIRS is very much into use. We all learned like that. Today's speaker is Dr. Dilip Kumar Mishra. He is from Agra, and he is very much academician, and he is known not only in India but across the Endourology Society. And along with Dr. Madhusudan sir, they have written a lot of papers. For those in India, many of them know him. But for the sake of introduction, so I am sharing the screen here for today's speaker introduction. So, today topic is ECRS by Dr. Dilip Kumar Mishra. He is MS, FRCS, MRCS, FRLS, FICS, and MCH Urology. He is consultant urology and head of the Department of Urology, Pushpanjali Hospital and Research Center, Agra. So, urology residency he did from KMC Manipal, which is a prestigious institute in India, in 2012. Awarded the JUA International Scholarship at Tokyo Medical University, Tokyo, Japan, for training robotic and laparoscopic surgery in 2012 itself. Awarded the UAA Youth Section Fellowship for the year 2014. These are all like those who are interested, those who have scientific work will be given these fellowships. Member of Royal College of Surgeons, conferred Fellowship of International College of Surgeons, Chicago, USA, Distinguished Young Urology Award, Urology Association of Uttar Pradesh 2023, won various awards and fellowships during his illustrious academic career and has 35 publications to his name in the peer-reviewed international journals. He is the chairman of Youth Wing of USI 2019 to 21 and eminent faculty of Indian School of Urology. So, reviewer of various urology journals like Indian Journal of Urology, Journal of Endourology, Asian Journal of Urology, Urothiasis, BMC Urology. Working on various academic papers, books, chapters in Smith textbook of Endourology, which is well known. Review articles on mini PCNL, international publications on PCNL and various instructive courses at World Congress Endourology and SIU. Edited book titled Mini Percutaneous Nephrolithotomy by Springer in 2022. Section Editor Endourology Section USI's Clinical Urology, CBS Publishers 2024. Multiple presentations, lectures at regional, national, international conferences. Clinical work involves special focus on endourology, stone disease, and reconstructive urology. At an younger age, he has done so much work, and there is a lot of future for him to do more such work. Let us listen from him about the ECIRS. More than good academician, he is also close friend of me. In fact, this meeting might have happened long before. At last it happened. Good for us. Thank you, Dilip. Over to you.
Thank you, Chandramohan sir. Am I audible?
Yes, please.
I thank you so much for inviting me for this talk, and it's a program which is very right in my heart, because it is such a nice program. I have been listening to this program since a long time, and I was wondering why you have not invited me at all. But you did invite. Actually, I only could not come forward with a talk. I remember that. And so now I have the opportunity, and I thank you very much for inviting me for this talk. And thank you for the kind words which you introduced me just now. And let me take this opportunity this pure program which we have started, it is so much helpful for the young urologists. They keep on learning things. They keep on getting new insights from the people who are coming and delivering lectures here. People from all over the world keep on coming here and deliver lectures here. And you keep on doing those monthly endourology programs, which so many young urologists come and learn from you. Even I have come and attended 2, 3 programs by you, and I have learned immensely from you, sir.
Thank
And the you keep on using so many conferences, sir. All the conferences are always houseful, and I keep on seeing you. I don't know how you have got so much energy. Every conference you go, you will demonstrate live, and in the evening you will be always on the dance floor, and it's so much energy you have, sir. I'm just so inspired by you.
thank
So thank you, sir, once again for getting me for this talk, and I would like to start. So this is a small pictorial depiction of how ECR is performed in a general operation theater, and I would like to.
Yeah, we are able to see that. Roll once, then it will scroll down. Roll once on the
Just
screen.
checking. Okay, fine.
Yeah, yeah.
So my talk will be going in these headings. I would discuss the history, positioning for ECIRS, equipment which we use for ECIRS, operating room arrangement for doing ECIRS, indications, advantages and disadvantages, and some concluding remarks. So coming on to the history, as sir has already told most of the history about ECIRS, but it is worthwhile to mention the name of this person, Dr. Ecirs Scofoni. He was the person who has really done a lot of work on ECIRS, and he started it. He published his seminal paper in 2008 on 127 patients, and he is the one who has set the ball rolling for in favor of ECIRS. So I would like to ask question to people, if people are there, that suppose this is a case given to you. How would you approach this case? And this is a case from I have taken from Twitter actually. And this was what was done by in this case by somebody, and I don't think it is justified to make 8 tracts for such a case. And then you have to put so many PCNs. All these things is not justified nowadays. So why ECRS? What's the fun in doing all the things together? So I would go one by one. What are the advantages of doing ECIRS? It's a versatile procedure. You see, you have the whole of the urinary tract under your control, starting from the tip of the penis or tip of the urethra to the deepest portion of a calyx, of a minor calyx. You have everything under your control. You can go from the urethra to bladder to the ureteric orifice, and you can go on to the both sides. So everything is under your control. And there is a precise vicinal puncture under visual guidance. You have your endoscopic flexible endoscope in place, and then you can make a puncture and you can see where the needle is entering, whether it's entering correctly or not. There is reduced X-ray exposure, and you can avoid making multiple percutaneous excesses. We all know that the amount of bleeding, which is the most dreaded complication of ECNL surgery, is directly proportional to the size of the tract and number of tracts you make. So if you can avoid making more tracts, you can avoid the bleeding complications. And there is also decreased intrarenal pressure and optimal drainage of stone fragments. So coming on to the second heading, positioning. So positioning is very important for ECIRS. Why? Because if you are not able to position it properly, it will be very difficult to do a puncture in ECRS. So no position is ideal in all situations. What are the disadvantages of prone position? You can see that there is always a need to reposition the patient. Patient will be in lithotic position once you put a ureteric catheter about doing PCNL, then you have to turn the patient prone. And if it is a heavy patient, you need 3 to 4 OT personnel for changing the position of the patient. There is always airway is always jeopardized because it's not always under control of the anesthetist. There may be difficulty in for morbidly obese and spinal deformity patients. There is decreased cardiac index by 24%. Simultaneous retrograde access is not possible in this prone position, and there is always a chance of peripheral nerve damage and ocular injuries. So, I'm sorry. when we are positioning the patient for ECRS, the markings is very important because you are making the patient in GMSV position. So once the patient is in normal supine position, you have to mark the posterior axillary line, iliac crest, and costal margin, because those are the landmarks which you will need to make a proper puncture, and you have to avoid making any injury to the nearby viscera or nearby other structures. So this is how we mark it. We mark the iliac crest, as you can see in this picture. You mark the 11th rib, 12th rib, and this is the shaded area which is the behind the posterior axillary line in this position, and this is the area from which you are supposed to make puncture in ECIRS. This is the original Valdivia position which was described by Professor Jose Valdivia, and in this you can see he just places a sandbag and turns the patient to one side. And this is how he used to do supine PCNL. It was not for ECRS, but just for supine PCNL. So once you have modified this position to GMSV, Galdakau modified supine Valdivia position. In this, you do slight fixation of the Valdivia position with contralateral leg is fixed. Here you can see the contralateral leg is flexed, and it is slightly extended, which is here. And you can achieve a modified death horton position in which you have access to the urethra as well as to the flank also.
Notification.
This is a small video. I hope you can see the video.
Yeah,
And
we can see.
In which we are placing the patient in for ECRS position. You can see already we have done the markings. So markings has to be done beforehand, and then you place the patient in this position as it is shown in this video. And it's very easy actually. You just turn the patient bring to the edge of the table, turn one hand to the other side, extend one leg, flex one leg, and then it's done. That's it. This is another position, another way of positioning, which is done by Dr. Guido Gusti from Italy. And he keeps this leg straight and just turns one arm to the other side, and that's how he does his supine PCNS. And this is one position which is called proximal position, which is popularized by Dr. Aditya Sharma from Lucknow, and he does his supine PCNS in this position. So what are the advantages of this GMSC position? So as I already told you, you have got endoscopic visual control to make a proper puncture. There is better and dependent drainage because the tract which you have made into the kidney will be either parallel to the floor or it will be slightly downwards. So every fragment will keep on coming down with the flow. And there is low intracranial pressure, and it's a very versatile procedure for treatment of urology because you have got access from both the sides, and you can use rigid instrument, flexible instrument, whatever instrument you want, you can use. And there is reduced percutaneous accesses because you have got flexible scope which can bring the stones back to you. It is also comfortable for the patient. If it is an obese patient, it is very comfortable because you don't need more OT personnel for positioning the patients. And there is less radiation, and there are obvious anesthesia advantages because the airway is always under control of the anesthetist, and he can do whatever he wants if needs arises. Now, it's not that there is no disadvantage of this position. The puncture generally is not so easy. You need to learn a lot, means you need to practice a lot to get to the crux of how to make a good puncture in supine position. The pelvic system is also less distended and than in the prone position because it is horizontal and slightly downward inclination of the ampla sheath. There is little difficulty. It might be sometimes challenging to make a supercalicial puncture, although it might not be so for Chandramohan sir. But for a beginner, it might be difficult to make a supercalicial puncture in a supine position.
Yes, sir. Supercalicial puncture is difficult, as you said.
Yes, sir.
Should not be attempted casually as much as in prone patient because you will not see the back so easily. You are correct.
Yes. You are correct. And the tract length which you are getting in supine PCNL is generally longer than what you get in prone patient because you traverse a lot of tissue in obese patients and otherwise also. There can be sometimes more torque on the renal parenchyma, and there is sometimes a little chance of more bleeding if you're using more torque. But that can be avoided because you are having your sheath in position, and the other work can be done by the flexible scope.
One small question, Dilip.
Yes, sir.
In the marking, you have shown nicely 2 videos. Did you mark in the supine position or sitting position? A lot of people will ask this question
yes,
before
I generally do the marking once the patient is anesthetized. So I will
Yes.
mark it in the supine position, sir.
Yeah, I will also mark in supine. Making even in general anesthesia, sitting and doing is cumbersome. Even
Yes, sir.
for patient without anesthesia doing in sitting position, if while cleaning it may disappear.
Yes, sir.
So
Yes,
there's no need to be so much about that.
yes, yes,
If you keep the limb parallel, it's
yes,
fine.
yes.
I think fine now.
Yes, actually, after a certain amount of time, if you're experienced, you will understand actually where is the
Yeah,
posterior
yeah,
axillary line.
yeah, yeah,
That is the
correct,
most important landmark.
correct, correct.
So I don't think it's required to do it in the sitting position. Once the patient is anesthetized, you can easily do whatever you want because it's easier for everyone actually. So one second. So I was on supine GMSC position, but then the certain people might find it difficult to make a puncture in supine position because it definitely needs a lot of practice and you might need to have an ultrasound machine in the OT. So it's not that you cannot do ECRS if you don't know how to do it in supine position. You can always do in a prone position also. This has also been popularized. And this is one paper which has been published in 2002 in which they have shown how to do ECRS in the prone split leg position. So what they do in this position is generally they will keep in the lithotomy position and then put in the access sheath initially, and then put the turn the patient prone in the split leg position, and then they have the best of both worlds. You have the access sheath already in place, and you can make a puncture as you do in a prone PCNL normally. So this also is coming up, and a lot of people have started doing this also.
Have you ever tried this prone split position RIRS? I have never tried. Did you try?
I have tried once, sir. The thing is, but generally, what I did was beforehand only I put a stent because I didn't want the accessory to do much damage. So I always did it in a stented pre-stented.
Can you show the position of that patient? Previous slide. Just just before
Previous
this
piece.
split prone.
1 second, sir.
Yeah.
This,
This position.
yes,
Many
yes,
people out of interest. Surya Prakash says that I have tried, and in India also people are doing.
yes,
I
yes, yes,
uh, uh, we should listen from their perspective, but it is
yes,
not popular anyway because otherwise supine PCL need will be gone if you have really done.
yes, yes. I agree, sir. The thing is,
Yeah.
the only advantage of this is that if somebody is not very familiar with the puncturing technique in supine PCNL,
Yes, yes.
then he can have the advantage of puncturing like we generally do in prone PCNL. We find out the uh, posterior calyx and do punctures. Similar thing can be attempted here. Only thing you need to have your access sheet beforehand, and you need to turn the patient again like in prone PCNL. So there are multiple papers which have described intracranial surgery in prone split leg position. You can see this is 2015 paper, this is 2023 paper, and this is a randomized controlled trial of ECRS in prone versus GMSC position. So this is how we position for prone split leg position. Here I have made this video. In this we did not do the ECRS. This video is just for demonstration how to make the prone split leg position actually. So we have marked the patient, and this is how you have to proceed if you are planning to do a prone ECRS.
Great.
So you
This
can see,
I have not seen often this position. It's nice to see.
you can see, sir, in this position, you get more area. If you want to make a proper puncture, you get more area like you do in prone PCNL.
Yeah, very nice.
Coming on to equipment. So, so to perform an ECIS, we need a lot of equipment, and a lot of team is required actually. We needed two very experienced urologists. One person should be much well versed in making supine PCNL punctures, and the other person should be well versed to do RIS in the tilted position. So, and you need two experienced assistants and nurses for the floor duty. There is additional personnel for managing the positioning and shifting of equipment. Then coming on to equipment, we need two HD camera systems with monitors. We need a fluoroscopy, and we use ultrasonography for making a supine puncture. So we need ultrasound machine also in the OT. we need energy sources. Generally, one energy source can do, because one side you can use the energy source for making fragmentation. It could be laser, it could be pneumatic or shock pulse, and the other side can just go on and use the basket to pick up a stone and deliver it to the sheath. And there has to be 2+1 instrument trolleys inside the OT. Then you need all the equipment like standard scope, nephroscope, mini nephroscope, flexible scope, everything which is required in PCNL plus RARS will be required in doing an ECIRS. So operating room management, this is very important. Why? Because there is a lot of equipment which is supposed to be fitted in a single OT with all the positioning. So I would like to show you how operating room management. This is one slide which we have prepared and shown in SIU also. Here, the patient is in the center. This is the anesthetist. This is the anesthesia station. On this side, where the percutaneous surgeon is there, this side is the percutaneous surgeon. The other side is C-arm screen, the C-arm, the ultrasonography monitor. And here is the surgeon. This is the assistant. This is the trolley for the percutaneous surgeon. And this is the monitor for the first surgeon who is doing the percutaneous procedure. This is the second surgeon who is doing RIRS procedure. This is the assistant standing right behind the surgeon, and this is the trolley for this. There are multiple. If suppose you omit the machine, then you can shift both the monitors in this position so that both the surgeons can have a combined view of what is being done. This is another which I have taken from some paper, how you can do arrangement in operation theater. All the things can be placed like this. This is I made a video from my theater, how we position the things. This is the patient in supine position. This is not for the patient, this is for the equipment. You can see this is the anesthesia area. Here the anesthesia trolley is there. Then there's the one first monitor which is for the RIRS surgeon. He can see he is pushed in this one. This is the C-arm which is placed. Other side is the C-arm monitor. Then we have got the second video unit in which the percutaneous surgeon will do. Then there's the laser unit. And this is the trolley for the retrograde surgeon who is doing RIRS, going to do RIRS. And then this is the trolley which is for the PCNL surgeon. And the PCNL surgeon can be placed here where the chair is there. So that is how you can place everything comfortably in a theater for doing ECIRS. This is a picture sent to me by Dr. Karthikeyan, who keeps on doing ECIRS, and this is a actual picture of his theater in which you can see Karthikeyan and other surgeons who are performing ECIRS in this position, and you can see everything as an actual OT arrangement. Coming on to indications. So what are the indications where you want to do ECIRS? So I would like to prefer doing ECIRS in these situations if you have a large bulk of impacted upper ureteric stone. So an impacted upper ureteric stone can be a really difficult situation for many urologists because it is impacted. You cannot access properly from here, from retrograde place. You cannot access because there might be kink in the ureter. It can be difficult to reach the upper ureteric stone. So if you are having a combined approach, it helps very well to do these kind of stones in ECIRS. Now, if you have got stagnant stone with multiple calluses involved, you need not make multiple punctures. You can make one big single large tract in the lower calyx, and then you can clear most of the stone from that. And whatever residual stones are left, you can do the passing the ball technique, and then you can clear most of them. Similarly, this is also a partial stagnant or stagnant type of stone. You can do ECIRS. If you are just doing PCNL, you need to make 2 to 3 punctures in this case. But if you are doing ECIRS, just one puncture will be good enough. If you've got multiple stones in different calluses, can be done with just by doing RIRS. But if you're doing ECIRS, it will definitely save time. And if you got stone at PUJ with suspected PUJ obstruction, you can definitely do ECIRS. And you can PUJ obstruction can be tackled by endopalatotomy if need arises. So this is our paper which we published in 2023 last year in Journal of Endourology, and we did Ecirs. We promote Ecirs for large impacted upper ureteric stones, and we found out that if you are just doing retrograde ureteroscopy or a mini PCNL, it is better always to do Ecirs, and it gets maximum stone clearance in this kind of cases. This is the abstract in which we had 60 patients in Ecirs group and 60 patients in different groups. So this is a short video of mini Ecirs which we perform in our center for upper ureteric stones. This is a rigid, semi-rigid ureteroscope which is passed into the ureter, and here we are making a puncture into the kidney, and you can see we are dilating the tract, and you can see with the ureteroscope you can already see how the sheath is coming into the system, and then the stone which was in the upper uterus is disinfected and went to the pelvis, and then we can easily fragment the stone. Here you can see from the ureteroscope, you can see how the nephroscope is coming in, and we can easily see the stone ureteroscope. By vision is there. Easily you can fragment the stone and it can come. And following this, you can easily place a stent or whatever is required. You have the whole tract under your control. So this was our book which we have published, and I also published another chapter on Ecirs in this book by Springer, which was published 2 years back. Now, this is another video on Ecirs, which was sent by my friend Abhishek. This was done in Nadiad actually, and you can see Mahesh Desai sir made this puncture, and in this they have nicely demonstrated how to do the passing the ball technique, and you can see both flexible vision, and this here the flexible ureteroscope is going, catching the stone and coming onto the flexible sheath and delivering the stone there, and then you can get that stone and come out. So this is how passing the ball technique works in ECIRS. See how nicely they are picking up the stones from the different calyces and bringing down the nephroscope, and that is being transferred to the nephroscope and it is brought out to the sheath. So people say ECRS will add up complication of both PCNL RARS. However, I say it adds up the advantages and negates the complications. So PCNL complications are minimized when you are doing ECRS. Bleeding is the most treated complication in PCNL, which is reduced by making a perfect puncture under guidance. Most of the times, the puncture is infracostal and low calycis puncture, and there is less chance of a hemo or a pneumothorax. There is no need to bend the sheath here and there, and so the torque is minimized because the sheath is in place, and the rest of the work can be done by the flexible ureteroscope, which will help get all the fragments to the sheath. And the access sheath provides a wide track to minimize the intrarenal pressure. So there is no fear of raised intrarenal pressure that might can happen in RIRS. And all the fragments are cleared in one sitting only. You do not leave anything behind. Everything, dust, everything is cleared. However, complication of RIRS, which could be because of raised intrarenal pressure, it is averted because the PCNL sheath is there and you don't have any rise in intrarenal pressure. IRS can be done sheathless or with a smallest sheath, so there is less chance of ureteric trauma. IRS leads to residual stone fragments. Here, all fragments come out completely clear, system is there, and there is no rise in temperature also. So, I would just say for the youngsters, always try to learn, unlearn, and relearn. I have almost done my talk, and you should learn always the newer techniques so that you can always be ahead of the track. So you should never be afraid to do a new procedure. This is me doing skydiving, and Chandramohan sir is such a nice example. He has got robot now, and any procedure you tell him, he is able to do it. So everything, any new procedure, you should not be able to afraid. You should not be afraid to do new procedures. So that's all from my side, Chandramohan sir. If there are any question, I'll be happy to answer.
Good, good, good. Last, when did you do that?
Which one, sir?
Huh? When did you do that diving?
That was 3 years back, sir.
Okay, you need some training for that?
No, no, no. You can do it in Dubai.
I mean, when you jump, you get feeling of vomiting or anything, where you have to where you have to learn, unlearn something how to. It's scary. You are attached to one person.
Which person?
No, you are yourself separate, or you are attached to one
No,
person.
no. I was tagged along with one person actually. You're not alone.
You cannot jump alone, no?
Not in the beginning. If you learn, if you do some 20-25 sliders, maybe you can.
Yeah, still it is risky. Don't do that. We need you, and patients need you a lot. So let's discuss some of the important points.
Yes, sir. Yes, sir.
Very common question I will ask, be honest. In the
Yes, sir.
sense, in the ECRS also difficult ureter, you cannot do it. For example,
Yes,
you yeah,
I
you
completely
agree.
agree, sir. If you have a ureter which is difficult, which your scope cannot go, obviously you cannot do it.
You
So
cannot do it.
in such cases, if you are contemplating that you cannot do it without ECRS, I would generally put in a stent and do it after some time.
Yeah, this is what exactly the question. When you feel that ECRS is necessary,
Yes,
like multiple stones in different cases with a large stone, you
yes,
have to be sacrificing one anesthesia and put stent and come out and give the best next time to the patient.
yes. Always, sir. Always.
Great, great.
If you feel that while doing uteroscopy, while trying to whenever we do RIS, you always do a semi-rigid uteroscopy first.
Yeah, yeah,
If time you feel that it is not going in easily, you should not go ahead. If you are planning to do just ECRS, you should just stent it and come back at a later date.
correct. So second thing, this is my over enthusiasm. In all the cases where the ureter is good,
Yes, sir.
if the stone is not a single one, I always put instead of ureteric catheter, small access sheath. Always. And
No.
I will ask the question and I will tell my opinion also.
Okay.
When I put a flexible scope and inject, normally when you inject ureteric catheter, sometimes inferior calyx or upper calyx may not be delineated if the stone is obstructing that lumen.
Okay.
Then ideal calyx which you have to puncture may not be delineated.
Okay.
And most of the us doesn't have ultrasound.
Okay.
Most of the Indians, you have you have a lot of research on that, and I also have. But most of the Indian scenario, ultrasound is not used.
Yes.
In that case, when I use flexible scope and instill contrast in the mouth of the infundibulum, then it will
Yes.
inject contrast and large dilatation can be seen. I am saying
Yes.
it is too much, but I put access sheath in most of the cases to have an access, even if I don't anticipate the ECRS. Is it justified, first of all?
Sir, I would say justified or not justified depends on the way the ureter has been. If you feel while doing semi-rigid uteroscopy,
It is very
ureter is good
accommodable,
enough,
no risk to ureter.
then I don't think there is any problem actually.
Yeah,
If
yeah.
Because it will be always easier with an access sheet to go in and come out
Yes,
again and
yes,
again.
yes, yes. By chance, if you have decided to go to the upper calyx for a small stone, by then
Yes,
you want to change, it is little cumbersome.
yes.
My
But the
third
thing is, sir,
question.
if
Yeah.
you are doing ECIRS actually, the thing is you don't need access sheath because all your outflow, whatever stones you are going out, are going through the PCNL sheath. So you just need to bring them to the sheath,
Yeah, yeah,
to the PCNL sheath.
yeah, yeah. So,
So in those cases means if you are doing RIRS without putting an access sheath also, that also should be doing
okay,
good.
okay, okay. That is possible. But one condition is that in ECIRS position, ureter goes slightly lateral. Sometimes getting access of the ureter in ECIRS position is slightly difficult. Normally
I
thought
agree, sir.
you directly go, but in
Yes, yes.
ECIRS, positional disadvantage is
Yes, yes.
if
I
access sheath
totally
is
agree
there,
with you.
if access sheath is there, that positional disadvantage is not there.
That's why I said you need a very experienced RAF surgeon also.
Yes.
And
Next question
yes,
is that only. Next
yes,
question is that only. See, unless it is absolutely indicated, 2 surgeons, 2 monitors is the one. Even if someone wants to unlearn, they are not unlearning because of this tedious job.
it is true.
Teamwork and 2 monitors. Some people say that no need, I will only go down, I will only come up. It can be done. And exchange the camera also, especially in the present era of same monitor. We have digital monitors. So you need not just plug out, plug in and 2 visions also can be there same time.
Yes, yes. I
So all
totally
these
agree.
luxuries are there. So who will accompany you in your theater when you do that? Because you are also private practitioner and you do in college as well as some of your favorite hospitals. How do you
So
address this?
most of the times when we have done ECRS, I have done with Madhusudan Agrawal sir actually. He is the one who has introduced me to ECRS actually, I would say.
Yeah.
And nowadays we have got DNB in our center and we have got DNB PGs. So there are third year PGs, there are second year also. At times, as you said, that I also can go from here to from the percutaneous track to the RIS track, I can go. I have done that also, and I have also asked my PGs to help me
Yeah.
do the retrograde surgery. They will just be holding, and I can guide them. Same because we have both the monitors in place. We can guide them to, do some work, or we can help them. It's not a like
Not an impossible thing.
yes, yes. It's easy. It can be done.
It can be done. My fourth question.
Yes, sir.
When did you, to my knowledge, you are a crazy prone PCL surgeon way back, at least 5 years back, to my memory. Suddenly, you also, once I have seen you SIU and all these things, shifting to this thing. What is the point that made you to learn supine PCL? Even in that case, I must appreciate Madhusudan sir also. Ultrasound guided, he learned in the early stage. He learned RIRS also. He learned supine also. He learned ECRS. Both of you have done teamwork. When did you do that supine PCL first one?
If you remember correctly, there was one workshop in our center when you had also come. I think it was in 2017 or sometime.
Yeah, one second, Mahesh Desai sir, I will take call and then
Okay.
sir, Mahesh Desai sir. Sir, I am in the pure urology talk, sir. Can I ping after 5 minutes? It's at the end of the session. Sir, please.
So, as I told you, sir, Madhusudan Agrawal sir was the one who has introduced me to this surgery. And you are also one of the person from whom I have learned a lot because you are the person who has switched from one to second to third so many times I have seen you. And you have done it so many times that I felt regarding what you said about prone PCNLs. So I am again telling you that I am still a prone PCNL person.
Yeah, you do it.
I am a prone PCNL person. If it's a single stone, if it is a PCNL which can be managed easily by just one single track, I will go ahead and do a prone PCNL only. But if I feel that this case definitely, as I showed you in the indication, that this case definitely requires multiple tracks or ECRS will help, then only we'll go and do ECRS. Otherwise, it's not that in every case I'm going and doing ECRS. If it's an impacted upper aortic stone in which requires two people or which cannot be done in single stage if you're doing once, like might have to stent it and come back later, then we might go ahead and do ECRS and finish it off in one go. So always we do ECRS in when it is indicated, otherwise we will not.
And then you are the right person to answer.
Yes, sir.
I still feel, honestly, a lot of people may not like this. I still feel sometimes supine PCNL inferior calyceal puncture is difficult. You you whatever in your imagination, it doesn't happen many times. Middle calyx perfect. Sometimes upper calyx better, but lower calyx somehow, thigh will come in picture. If the leg is not ECRS position, I must say in
Yes.
ECRS position, uh, do given choice in a pelvic stone, honestly 1.5 centimeter, both are good systems.
Yes.
Do you think which surgery is easy? This is not controversial. It's opinion, your opinion. That's all.
No, I didn't get you, sir. Means you are
So
saying that
stone
this.
versus supine, simple pelvic stone, 1.5 centimeter stone is
I will go
easy
for
to
prone.
learn, to
I will tell you my
practice to
opinion.
date for you.
I will go for prone PCNL.
Prone PCL. So
Yes.
prone PCL is slightly more easy in puncturing. And
Yes, definitely.
so honestly,
Not only puncturing, sir, dilatation also is easier in prone PCNL because your
dilatation also
hand movements are easy actually.
easy.
In
Correct. So in selected case, that's why a lot of people argue that supine is not good, but better to learn and keep it with you for
yes,
today's topic only ECRS at least.
yes,
At
yes,
that
yes.
time, you should not say that I don't know supine PCNL. For that, at least, do you agree or not?
I
So
agree
there is
completely.
nothing wrong in learning supine PCNL. It is a definitive scientific method. It's not that experimenting method.
No,
So
no, it's not at all, sir.
it's not at all. Now coming
Yes.
to the sixth point,
Hmm.
if stone is there in multiple calyxes, 3, 4, in
Mhm.
supine, again same question, which calyx you will choose so that other things are managed by the, is it
Flexible.
a large stone bearing one you will attack or easy calyx you will attack? What is your
Uh, it depends, sir. Suppose if you say that the large stone bearing calyx is a high up calyx, upper calyx, and you are going to have difficulty in getting that puncture in supine position.
yeah,
You very well, because in prone position also sometimes I get a stone which is packed into the lower calyx,
yeah,
and I don't make a puncture in the lower calyx. I'll make a puncture in the middle calyx or some other calyx, which will give
yes,
me a good access to the lower calyx, and you can easily retrieve that stone.
correct,
Similarly, here also, you make a puncture in a calyx because you have got the flexible scope which is there for you, and you can easily go maybe fragment the stone into large pieces and then bring them out from there and place it in front of the sheet and take it out, sir.
yeah, correct. Very, very important point that in ECRS, there is one more advantage is that you can choose the calyx. You need not be always inline axis with stone. You can
Yes,
modify a
yes,
bit.
sir.
You can
Yes, yes,
modify a bit.
yes, sir.
Number
That is the advantage.
sixth question. In ECRS, uh, large stone, small stone, do you use both pneumatic and laser? So PCNL part pneumatic and the laser part in, because there is no other way in RIRS. Or generally in PCNL, do you use laser? PCNL?
No, sir. What you asked me that if it's a large burden stone, and if you have a good calyx, which can give you a 24 French access, actually,
Yeah.
then you go ahead and make take pneumatic because pneumatic will work very fast. You
Yeah.
can fragment the stone faster, make it into larger fragments, bring them out quickly.
Yeah.
And then once you're done with the major bulk of stone, the smaller parts which are left with, that you can go ahead if need fragmentation with flexible scope, you can do with laser
Correct.
and
Correct. Correct. So exactly the migration of the stone with pneumatic lithotripter in ECRS worry will not be there.
not at all.
There won't be any much worry. A small stone goes, you can quickly pick it up and
Yes, sir.
back.
Yes, sir. Yes, yes.
My seventh question. Uh, if flexible scope is there, will you inspect all the calyxes at the end? Naam ke vaste, so that I am not leaving any calyx or not necessary.
So the thing is, when you're doing Ecirs, you already have a CT scan with you,
Yeah,
isn't it? So, and when you are progressing along with your surgery, you know that where your stone is, where your other residual stones are there, or if anything is there, which might have migrated with your fragmentation. Then definitely you need to look around here and then. It's not a big deal. In 2 minutes, you will be able to see all the calyces with the flexible scope. And your CRM also is there. So everything is there at your disposal. You can choose and decide whether you really need to go ahead and inspect each and every minor calyx to see whether it's cleared or not. And Once you're comfortable, you see that your CM doesn't show any residual fragment, and you have seen that you have done your fragmentation very easily and removed everything. It's not a
Not a,
hard and fast rule that you need to go and inspect everything. If your
yeah.
CM is clear, your nephroscope view is clear, maybe you can go away with it.
The eighth question. Sometimes stone lodges by the side of the ampla sheath, which is impossible to remove with the nephroscope coming back because it's at the edge of the parenchyma, it bleeds. In those cases, going by the side of the ampla sheath flexible scope and quickly bring it out is, or you can guide the nephroscope with flexible scope. Okay, here is the stone, you go there. Normally, when you search for a small stone, you are not able to go. But flexible scope will give a great idea. What is your opinion?
So, first of all, sir, that if you are having a stone in a parallel calyx, which is just adjacent to your sheath,
Yeah,
it's not a good idea to make some talk and go into that calyx
yes, yes,
even by
yes,
guided by that. You
yes.
have a flexible. You should
You
use
should
that
go with
actually.
flexible. That is another area where it happens most often that either it is dislodged or it may be there in situ. Then your flexible scope will help a lot.
Yes, yes, definitely, sir.
Now, the ninth question, lot of people argue that I can do whatever you are doing with 14-13 French bioroid nephroscope because it's highly flexible. So in prone, I will not do multiple punctures as you are claiming. I can do your picture also shows that some people are very good in flexible nephroscopy, but my problem is I can see the stone, but I cannot do anything with that. I cannot do
Sir,
anything with flexible nephroscopy. What is your
sir,
opinion?
with the flexible nephroscopy, the problem happens mostly with orientation actually. Because once you are doing a RARS, you are going from the PUJ and you know
Correct.
where everything is.
Correct.
But once you are entering from the PCNL tract and introducing a flexible nephroscope, sometimes the the area is not enough for it to flex and go into every other place. And the orientation also, you need to learn a lot, you need to practice a lot to get the orientation of the pelvic calcium system once you are using flexible nephroscope from the PCNL tract. So I would say it's always better to use the retrograde scope for doing this than using a flexible nephroscope from this one. The the pelvic calcium system may
I
not be
also
that
feel the
distended.
flexible ureteroscope has a better orientation, easy to use laser, easy to basket than flexible nephroscope.
Yes.
Very good. This is an important question actually answered by you, that we all feel that the ureteroscope is easy because we routinely do it. Flexible
Yes.
nephroscope, unless you have good CM guidance, a good space inside to move.
Maneuver it. Yes.
I have broken one scope initially starch where the extra length, it's very difficult to accommodate in the PCS, collapsed system.
Yes.
And
Yes.
water outflow, inflow logistics are also little difficult in everything. Water will be coming out and blood will be seen. Correct.
Yes. Yes.
Now, coming to the last part, uh, in the future, uh, if flexible scopes become very small, ureteroscopes, for
Yes.
example, 5 French, 6 French will come. Do you think that their utility will be increased and thus ECIRS will be much more used? Is your feeling even RIRS will be the primary treatment, and large volume you cannot do anything. For those, you finish supine PCNL and give, as you said, keep an access to the penile urethra for putting quickly over the guide wire. Quickly you pass the scope and see whatever the small part finish and come back. Do you think this has a future role?
Definitely, sir. Because as the technology is improving, the scope will become smaller and smaller. You might
Yeah.
have a 5 French scope with a good channel also, and everything is fine. They might be a little bit fragile, but then you are not going to do a staghorn stone with a with RIRS in one sitting. So for ECRS, definitely it will be an advantage actually.
Advantage because combined
Yes,
technique.
yes,
So,
yes.
thank you very much, and it is a very good answers. Actually, I whatever I was thinking you crisply answered without any bias. And stones in India recently, I have seen from your place only and Delhi in these 2 months. A lot of people are sharing that Chandramohan sir, we are seeing still large stones. We are doing daily 3-4 PCNLs large stones. So PCNL is a surgery which will be there forever in India. I also agree. Maybe our grandchildren also will accept that. Uh, Good prone PCNL and supine PCNL mastering is very useful, I feel. I hope you agree
Yes,
with
sir.
the same. You have to learn. After all, this is bread and butter surgery. There is nothing wrong in learning supine PCNL instead of arguing daily that I never required, I never do. These are the small places where you don't want to puncture upper calyx for 1 centimeter stone, and you have done so much bulk in lower calyx. Get that upper calycial stone in 1 minute and give to the
Yes, yes.
next person. So you should not deny that. So
Yes,
I
yes.
think this subject will continue and hope we will. I also wanted to do proper prone PCNL CM based talk, because your visuals are always impressive, because you go to abroad and present. You in the coming 6 months will come back for prone PCNL CM guided puncture, not ultrasound guided puncture. Uh,
Definitely, sir. I'll do it. No
because
problem.
it's your favorite subject, I know, and I will be very happy to listen that from you. Please
Sure, sir. I'll prepare for that.
prepare that nicely, like they say
Okay.
today, and it will be very, because next generation 300 members every year are coming, and half of them don't have facility to learn PCNL properly. So this is a continuous. For me, it's easy that people like you accept and then present. Then it's easy for me. That's what I wanted to say.
Yes,
Thank,
yes.
thank you very much.
Thank you so much, sir. It was a very nice discussion with you. I really